Here we go. And today we have Jessica Drummond here. She's got all these letters behind her name that I don't know what they mean except for the certified health coach. She is the founder and CEO of the Integrative Women's Health Institute and is passionate about caring for and empowering women who struggle with women's and pelvic health conditions. She is equally passionate about educating and supporting clinicians and coaches in confidently and safely using integrative tools to transform women's and pelvic health care. Having over a decade of experience as a women's and pelvic physical therapist, which blows me away, over a decade, you don't even look old enough for that, plus owning a private women's health clinical nutrition and coaching practice gives her a unique perspective on the integrative conservative options for pelvic pain management. Jessica was educated at the University of Virginia, Emory University, the Institute of Integrative Nutrition, which many of us went to, and Duke Integrative Medicine. She is currently a doctoral student in clinical nutrition at Maryland University of Integrative Health. Wow. That is a bio if I've ever heard one, Jessica. Really a lot. And we were just talking before I hit broadcast for you guys to join us about how much she's got going on and how much I have going on, how overwhelmed I am, and how she's just kind of cool as a cucumber here. So we're going to learn so much today about hormones. But what I'd love to hear about before we go into the presentation is I would love for you to tell us how you got interested in the pelvic health part and just women's health in general. Like, where did that come from for you?
Well, I graduated, actually, I need to probably update my bio. I graduated 17 years ago from physical therapy school. And like many people who go into that field, I went in with sort of a sports medicine bent, and I did outpatient orthopedics and sports medicine, and I was an athlete as a kid. And so, but pretty quickly, like within the first year of practice, I met a patient who had had breast cancer surgery, and she had a shoulder injury because of the breast cancer surgery. And that's why I was working with her. And from there, I started to just become more and more interested in women's health and supporting patients pre and post breast cancer, and then during and post pregnancy and delivery, because you know, I was always working with people with pain conditions, and they were in these unique situations in women's health where there was no medicines for them. You know, in pregnancy, the doctors don't like to give a lot of medicines, and so they're looking for anyone else who can help because
Right.
they're like stuck. And so a lot of pregnancy, and then with pelvic pain, which is very complex. It was always my most challenging patient population. And so and I worked with all kinds of women's health conditions. Within about the second year or third year after I graduated from graduate school, in practice, I was working at a specialty women's hospital where I worked off and on for about 8 or 10 years. And I worked at Duke Hospital in the same kind of role, and even working with women who were on bed rest for pregnancy. And then after I had my first daughter, I had a hormonal issue, which I didn't realize at the time. I didn't know what the heck was wrong with me. The doctors were like, oh, you know, like everybody else in this field, just take an antidepressant, or, you know, go take a nap. You know, you had a new baby. You're supposed to feel like crap, you know. And, you know, of course, my baby was like 3 at this point. And I'm like, really? Still? You know, but.
Toddler. She's a toddler now.
Yeah. But so, you know, finally, which is how I found functional medicine, and I started learning about nutrition. And what I realized from a kind of then taking that clinical experience that I had already had and recognizing that a lot of women with pelvic pain also have hormonal imbalances, and starting to marry the two, because we really have to work with everything when it comes to chronic pain. We've got to work with hormonal imbalances. We've got to work with pain science, which is really a lot about brain health, immune health, and which is now kind of almost the field of psychoneuroimmunology, certainly endocrine health. And pain science is also a lot about behavioral health, how afraid people are of their pain, or the words that we use around pain, or any history of trauma, you know, from early in life. So it was very just a sort of organic path to bring together all of these different perspectives.
Yeah, I loved your interview with Joe Tata that day on the Pain Summit. I bought the Pain Summit, of course, because I struggled with chronic pain for about 10 years, off and on for the last 3. So a total of probably 13 or 14 years of chronic pain with no solid reason why it's happening. So when that Pain Summit came out, I was like, I'm not even going to try to listen to the first day. I'm just going to buy it.
Yeah.
And it was, I kept walking. I passed my house twice with my dog, and because I didn't want to go in, because once I walk in, I'm focused on something else. So I walked the whole time so I could listen to the whole thing. It was very, very good. You said things that hit home for me and had me thinking of my own clients and friends that were dealing with many problems with pain. Pelvic pain in specific, I have a friend with a vulvodynia I think I've told you about. That is something that absolutely fascinates me, because she's been happy to sit on an antidepressant for all of these years, 6 years now, doesn't want to stray into that. She's fearful of that. So I find it interesting that you have so much to offer in that way, and yet people are afraid to go there many times.
Yeah, I think that's with anything that's new or relatively pioneering. But and I think the challenge with the way we work with clients as coaches, even though I have a lot of clinical letters and all these degrees and licenses, I now focus. I always begin my patient relationship in a coaching relationship, because coaching is really about co-collaboration, co-creation, leading of the team by the patient.
Yes.
And it thus requires a lot of work from the patient, a lot of behavior change. And that's not always easy, and it can be difficult. There are a lot of barriers to that we have to, as skilled coaches, support our clients to work through.
Yeah, that's so true. That is so true. And, one of the things I and we'll get started in a moment, but I do encourage the coaches that I teach to make sure that they work on is working with their clients on honing in on those instincts that maybe we've been silencing all of these years, or listening to our own self and our own story and our own voice about what could be happening inside of our body. So to me, I think that's something that is overlooked a lot when people are working with others. They want someone else to tell them how to fix the problem, instead of saying, oh, you mean I have to pay attention to what I'm supposed to be feeling and what I'm supposed to be, thinking about my own self. So yeah, so I love that. Okay, so let's do this. Let's go ahead and get started with the presentation. We've got time today, but I don't want to miss a thing. I'm excited to look at this as a woman who has been through perimenopause, surgical menopause, right? And a hysterectomy. I'm interested in watching every bit of this. So I've been waiting. I'm going to go ahead and pass this screen over to you and let you take control. And if any background noise happens on my end, I'll be sure to mute my microphone.
Okay, so I'll go ahead and just start the slides.
Yes.
Let's see. Here we go. All right, can you see that full screen?
Yep, we're good.
Okay. All right, so we're going to learn about hormones today. Don't panic. This is the biochemical pathway I expect you to memorize by the end of this talk. Just kidding.
No problem.
Genetics, everything. So the truth is that the biochemistry of our hormonal system is pretty complex, and there are a lot of genes that modulate all of these different reactions, a lot of enzymes, a lot of coenzymes. But the bottom line is there is an interplay here which we can simplify to help us manage it clinically, and that's what we're going to do today. So we're going to talk about the basics of the hormonal pathways, how the sex, stress, and thyroid hormones interact with each other, just how to find out if your client simply has a healthy menstrual cycle. Certainly every clinician who's working with women or coach should be just screening there. So we'll use the menstrual cycle as a general health indicator and look for red flags. Also, I have so many perimenopausal clients, and I'm sure a lot of coaches do. And what's fascinating to me is that very often when you're working with perimenopausal clients, perimenopause and puberty are living in the same house, which is fascinating. It's doing such in my house, which is really interesting. So we'll talk about that a little bit. I think, when we're talking about growing our coaching practice, just really thinking about women on all ends of this spectrum, because I actually think that girls are quite underserved, postpartum women are quite underserved, perimenopausal women are quite underserved, and there's a lot of room for this work in your practices. And then we'll get into some of the things that we can do across the lifespan. So what are hormones? I think, sometimes we have to get back to the basics. Essentially, hormones are the chemical substances. They're messengers that are synthesized. They're made in small amounts by the endocrine tissue, and then they're carried by the bloodstream to another tissue. They act as messengers. And thus, they regulate the function of whatever the target tissue is that they're going to. So we're going to be focusing mostly on steroid hormones today, although insulin plays a role, which is actually a polypeptide. Things like corticoids, which is cortisol, we call that cortisol, and sex hormones. And essentially, these are messenger chemicals that give messages to the target tissues. So we're going to be talking about these different pathways and how they interact. So one thing to recognize is that all of these hormonal systems begin in the brain. So when you are feeling stressed, when your client is feeling stressed, this is the hypothalamic pituitary adrenal axis. So the old terminology, we used to say, oh, we have adrenal fatigue. And the the mechanism that we thought was happening was that the adrenals were being told by the brain day in and day out to kind of buffer stress, because we live in kind of a 24/7 stress zone right now, which is very different than how we evolved. How we evolved was to live with fairly acute stress on a very irregular basis. So literally like being chased by a tiger, but you're not going to be chased by a tiger most days. Most days you're just like living and, essentially hunting for food. It was a survival time. You're trying to get food, you're just surviving. And now, we have access to a lot more relative safety, but we have these chronic stressors. We've got cable news, we've got our cell phones, and we have a lot of work. We can work 24 hours a day. We have, relationship stressors. We have financial stressors. And these are not the same, because when you're running from a tiger, you're physically making a response to that stress. Whereas if you're sitting at your desk reading something stressful, there's nowhere for that energy to go. You're not like getting up and running. You're just getting these hormonal messengers sent into the body, and then you're just kind of having to sit with that discomfort. So the stressor impacts the brain. It's a thought you have about something that's going on in your life more often than not now, or it's inflammation, which is often because we're eating bad diets, or a lot of sugar, or we're exposed to environmental toxins. We're under stress, which in itself causes inflammation. So then the hypothalamus, which is a part of the brain, secretes CRH, corticotropin releasing hormone, which again, remember, that's a messenger. It lands at the pituitary and tells the pituitary to release adrenocorticotropic hormone, ACTH. That hormone, again, is another messenger which tells the adrenal glands to release cortisol, because there's a stress going on, and cortisol is a relatively anti-inflammatory hormone, although it modulates the immune system, and you will get some inflammation when you have low-grade stress all the time. And so you'll have these inflammatory cytokines released. You'll have cortisol impacts the intestinal lining and makes it more permeable, or otherwise increases leaky gut. And then you have immune system responding to foods, and you get, this vicious cycle where then back via the vagus nerve, or just plain through the blood-brain barrier, these inflammatory cytokines can go back into the brain and stimulate more stress. So what we want to do is break the cycle along the way. Now, there's two other hormones that you need to be aware of for the adrenal, the hypothalamic pituitary adrenal axis, is noradrenaline and adrenaline. So if this system becomes dysfunctional, and the adrenal glands really are kind of the broken piece, the dysfunctional piece of the system, sometimes it's the brain that's inflamed, so the hypothalamus or the pituitary will be really the issue. But sometimes the adrenals are not functioning really well, and so cortisol levels can be quite low, and then what happens is noradrenaline and adrenaline are released instead, which that's when our clients feel really anxious, or they wake up with panic attacks, because the system has broken down, and you actually feel that adrenaline rush kind of out of nowhere. So a number of different stressors can impact the stress response system. So actual stress, emotional stress, a real physical stressor like, I'm about to get hit by a car, and you run out of the street, or circadian rhythms, and we'll talk about some others. So if your clients aren't going to bed by 9, 10 o'clock, if they're staying up really late, if they're exposed to a lot of blue light, these stressors impact parts of the brain, the PVN. If you look on the left side of that diagram, that's the area where the hypothalamus is, and we start that whole cycle of CRH, ATCH from the pituitary, and then the adrenals release cortisol. Now, the brain also, a different part of the brain, speaks through the spinal cord to stimulate the medulla, the outside of the adrenal glands, to release epinephrine and norepinephrine. So again, if your whole kind of sympathetic nervous system, which is the part of the nervous system that keeps you ready for fight or flight, is always turned on, there are a number of different pathways where you get these hormone releases that perpetuate that excessive vigilance in our bodies. So on the left side here is the same thing, the hypothalamic pituitary adrenal axis. Now, what I want to show you about this slide, again, you don't have to memorize all this, is similarly, we have a hypothalamic pituitary thyroid axis. So the hypothalamus will release TRH, stimulating the pituitary to release TSH, stimulating the thyroid to release T4. This is the free-flowing T4 that's in the circulation. Some of it will be converted to reverse T3, which is a competitive inhibitor of T3. Some will be converted to T3. And T3 is the active form of thyroid hormone, which then can can enter the cell, can bind to the cellular nucleus, and can essentially cause the DNA to be read, and that DNA then is read as mRNA, and it increases mitochondrial function, which is how you have energy when your thyroid is not working, while your metabolism is so screwed up. So that's when we have clients that they're low thyroid. So either this T3 isn't functioning well, or the T4 isn't converting into T3, or it's all the way up here at the brain and we're not having TRH and TSH released appropriately. Now, what's important about this is cortisol, one of those key adrenal hormones, can block the thyroid pathways in a number of places. So if you have too much cortisol, that will inhibit TSH. It will also inhibit the conversion of T4 to T3. So these systems are not independent of each other. Also, if you have way too much CRH, that will also inhibit TSH from the pituitary. So when I'm thinking about working with a client who's having hormonal imbalances, I always start with the hypothalamic pituitary adrenal axis, because you can't fix the thyroid axis or optimize the functioning of the thyroid axis if the adrenal axis is not functioning, because it just gets in the way. The hypothalamus could be perfectly fine. The thyroid in itself could really be perfectly fine, but its action is being bothered by the stress response system.
I love that. Yeah, this is a great chart because, it can be very difficult to explain to someone that is taking thyroid medication or has been told their thyroid is sluggish or slow, or they have hypothyroid autoimmunity or whatever, and they've been given a pill, but then they don't feel good. Because usually the practitioner or the doctor has not explained that, well, your adrenals have to be in good enough shape to be able to handle any kind of stress on the thyroid, which sometimes medication can be stressful to the thyroid, right? If we have the wrong kind or whatnot.
Well, sure. Like if you have, for example, you've got a person with thyroid issue who's exposed to gluten or something like that, you can have an immune system response, and that immune system response will release inflammatory cytokines going back to the brain and mucking up the hypothalamic pituitary adrenal axis.
It's like a broken link. So that it creates a broken link when they cannot communicate with each other. This is great, though. Let me just say this real quick, because someone's going to ultimately ask, because that's how my students are. That is so funny. Kathy, I was just addressing this. Yes, you guys are going to get an opt-in link to get access to the slides. That is what I was just going to say. So yes, absolutely, you'll get you will get access, and I'm going to opt in because I want a copy of this chart because it's so beautifully done.
And I have the reference for this. I usually have it right on the slide. This is from a really excellent paper. I don't know, sometimes when I recreate slides from other presentations, I forget to transition over the references. Usually I don't, but I'll find that. I have that paper somewhere. So if you want to read the whole thing, it's a fantastic paper.
Okay.
So, all right. So then the other key thing is, all right, let's look at, so we've looked at the adrenal axis. We've looked at the thyroid axis. Now let's look at the sex hormone axis. Sex hormones created from cholesterol. And this is from this reference right here, this image. So cholesterol. So if your clients are not eating adequate fat, their cholesterol is too low, they're going to have problems with their sex hormones. Then that converts into pregnenolone, which converts into a number of mediators, and then into progesterone. So that's the first. However, the problem is sometimes we get this little steal. You probably heard of the pregnenolone steal. And that essentially, again, going back to the hypothalamic pituitary adrenal axis, cortisol is always prioritized. Now, these are all these more scientific names, but just imagine this little yellow area is cortisol, okay? Cortisol is prioritized 100% of the time over the making of your sex hormones. So if you only have limited raw materials, only limited fat, your body's going to make cortisol if you're under stress instead of sex hormones. And then you'll have some sex hormones.
Survival is more important than procreating, right?
Correct, because cortisol is a survival hormone. And so, but, estrogen has over 300 receptors in the body. So even if you're not trying to get pregnant, you're going to be feeling like crap. So now if your clients are struggling with infertility, it's the first thing to go back to, the adrenals, okay, or the HPA axis. All right, now assuming you're not under excessive stress, various intermediaries, and these little like capsule looking things are genes. They're the gene codes. And so all of these genes need to be functioning. So if your clients are having significant genetic SNPs, they may not have the enzymes or efficient enough workings of these enzymes to be essentially bringing this cholesterol molecule all the way through the pathway from pregnenolone, then to DHEA, then to androstenedione, which is converted into testosterone, or via aromatase to estrogen. So testosterone or a couple of these other androgens can be converted to estrogen. If you're on aromatase inhibitors, then it won't convert as well to estrogen. These are just different kinds of estrogen. We don't have to get into the detail today, and then sex hormone binding globulin is really important. Sex hormone binding globulin is a protein that ties up your testosterone and your estrogen. Also, there are other binding proteins that are involved with progesterone and cortisol. And interestingly, the birth control pill elevates sex hormone binding globulin, sometimes permanently. We have some data that shows it's difficult to reverse that. So if you have a client who's been on the birth control pill, it may be very difficult to get normal sex hormone levels back if she's trying to get pregnant after that.
Interesting. Tell me about the now the SHBG is something I started asking for testing for myself about 5 or 6 years ago, because I was hearing about the connection to testosterone, and I was dealing with low testosterone at the time. And so she said, well, let's check the SHBG and see what's happening there. Well, I was high in SHBG, which is interesting because I'm hypothyroid. Many people with hypothyroidism, don't they have low SHBG? Isn't that common?
Well, it can be. If you have low sex hormone binding globulin, that's also a problem. All of these hormones want to be kind of right-sized because, and proteins, because if you have very low sex hormone binding globulin, you're going to have too much estrogen, usually for women. For men, maybe testosterone, and for women, too much estrogen, which causes other problems like fibroids and, breast cancers and breast tenderness and PMS. And so there are problems with having too much estrogen as well. So people on vegetarian diets have higher levels of SHBG, which is generally good. It's cancer protective. But too high, and you start having problems. You might have pain with orgasm, vaginal dryness, brain fog, because estrogen modulates a lot of brain neurotransmitters, difficulty getting pregnant. In fact, there's a great study on vegetarian women, young, healthy vegetarian women whose SHBG is too high, and they actually have anovulatory cycles. So they may have difficulty getting pregnant, not understanding why. Everything looks fine. So estrogen is then broken down. So in this little yellow box, you see there's a lot of different pathways for the breakdown of estrogen as well, which we'll come back to. Some of these are healthier than others. And all of these sex hormones need to then be able to get into the cell so they can be involved in GNA expression and doing the work that they do, depending on the cell that they're interacting with. All right, so that's kind of the overview of the pathways. Now, you want to start asking your clients, you want to start having them really tune into their menstrual cycles. Most clients know that their menstrual cycle exists when they get their period. Right. In between, they're like, I don't have my period. I'm not on my cycle. You're always on your cycle. You're always having a cycle. Interestingly enough, men are always having a cycle too. Theirs is just daily rather than monthly. So it aligns much better with the workday, which I think is fascinating. So if we just look at the three key hormones here, estrogen is this like yellowish line. And essentially day one is the first day of bleeding. Then estrogen steadily rises until just right before ovulation. And then it triggers ovulation at its highest point along with LH and FSH. And then after ovulation, estrogen drops down for a couple of days, and then it comes back to sort of a moderate level. And all of the hormones go back to their lowest levels right just before and the few days that women are actually bleeding. Progesterone is lower in the follicular phase, which is that first half of the cycle, but then it's the dominant hormone in the luteal phase, which is the second half of the cycle. Testosterone is relatively low for women all the time. However, just before ovulation, it's at its highest for women for a few days before ovulation. So one of the things that's really helpful for your clients that are having libido issues, especially if they're perimenopausal or they've got some hormonal suppression for some reason, is to have them start to tune in to those few, about a week and a half actually, prior to ovulation. They should be feeling more libido. They should be feeling energized. They should be feeling their most masculine. If you want to kind of think about masculine energy as being productive, but it's also the most sort of sexy time for women. Our skin is clearer. We have a lot of energy. We're more, our sexual appetites are stronger. Libido is highest because testosterone is highest. So if we were to design the workday, we would ideally have a couple of days off when we have our periods. Then we'd be like crushing some amazing projects or training hard for the marathon or whatever, going out on dates, like doing all kinds of fun things for like a week and a half from about day, it depends on how healthy you are, but if you're optimally healthy, like day 5 through about day 13, 14, might be a little bit shorter window if you're perimenopausal or you're having some hormonal issues, but in kind of an ideal world. Then the last half of the cycle, when progesterone is dominating, we are more intuitive, we're more creative, we have better connections with women. So if you're going to go into some kind of a negotiation or you're going to be doing a creative project, this is how, when it would be optimal. And so I think it's important to have clients start tracking these things and noticing how they feel. A really simple app that we use is called Hormone Horoscope. And it's done by a writer, not even a medical professional. She's like a researcher. And it's a nice kind of fascinating little emotional tracker. I don't agree with 100% of what she's written there, but I think it's really helpful. Or we can just use things like Period Tracker and show them this map and, have women start to tune in that there are normal ebbs and flows. We are not supposed to feel linear. We, as women, part of our feminine flows are cyclical, not linear.
That's interesting to hear too, because Dr. Keisha Ewers was on last week, and she was talking about libido, of course, and talking about sex drive, and that she said, I have sex every day. And I was like, okay, hold on. We have to stop right there. And I need like an elaboration. How do you want to have sex every day? Right. And she was talking about the fact that she has no expectations. Like, many times, men think that we're supposed to be on all the time, right?
Mm-hmm.
But we aren't all on all the time. I mean, you sharing that part about where we're supposed to feel the most sexy or the most, desire or whatever, that's very interesting. I've never heard anybody talk about it as a part of a flow in our lives, the way we ebb and flow. Very interesting.
Yeah, because it's certainly fine to have sex every day. I mean, if you're interested in having sex every day, it's no problem. But hormonally, there are going to be natural, testosterone is our libido hormone, and it's really we only get a big pulse of it, a week or so before ovulation. And that's clearly evolutionarily makes sense, right?
Right.
That's when we should be having sex if we want to get pregnant. So, and then beyond that, there's certainly healthy things about having sex at any other time in the month. That's not a problem, but it's a matter of, I think, tuning into what your body is feeling at different times. There is natural shifts in what you're going to be desiring and what your body is going to need. And it's not necessarily always going to be sex. It might be more of a girls' night or, staying home and going to bed early.
Yeah. I know. I was absolutely floored when she told us that. I'm like, oh my gosh, I have to admit to a little bit of envy there.
I'm not. I think that would be exhausting because you have to nourish all of these different things.
Yeah, true. It's true.
But hey, that's great. I'm all for that.
Gabriella was asking about her, what about postmenopausal women? That's a great question. If you're going to talk about that as we go on, that's fine. But what about the people who don't have the ovulation? Tell us how we're supposed to be tuning into that low libido time and the impulse and all of that.
Well, so for postmenopausal women, there isn't as much of a variation, clearly. Now here's the trick for postmenopausal women. You want to, as coaches, start working with women, ideally more like in their 30s or early 40s. It's harder in a natural way, using nutrition, supplementation, lifestyle, to optimize estrogen post-menopausally, because the estrogen that you have post-menopausally is primarily made in your adrenals. And so you have to have just rock star adrenals going into menopause. And then in menopause, you'll feel plenty of libido. You have all the estrogen that you need. But if you're like stumbling over the finish line, like dragging, it's very difficult to kind of restore that post-menopausally if your adrenals were tanked when you got there. So, or your HPA axis was tanked. Maybe your brain was inflamed, whatever. Now, it doesn't mean that you shouldn't try. I would absolutely focus on adrenal health if I have a post-menopausal woman who's having challenges with libido. But, those are the clients that more often need bioidentical hormone replacement or things like that. So, and then in terms of flow, it's interesting. As I said, it's much more stable postmenopausal because it's kind of like pre-puberty. You don't have a cycle. However, I think there's some nourishing things about tuning into cycles. So maybe you start tuning more into the circadian rhythm or seasonal cycles or the cycles of the moon. And you're not going to have the same internal drive, but you can connect with nature and get some way to organize the cyclical sort of action and rest that I think women need at all stages of life.
Good. Yeah, Gabriella says, so we are more free.
Yeah, I mean, postmenopausal, it could be any day, which is great.
Yeah. Don't tell our husbands.
That's right. And tell them anything you want. And men, men's testosterone cycle is highest at about 7:45 in the morning. It's fascinating. I had to do like a local news show about this one morning, and it was like the early morning, like I'm being interviewed by this male anchor, and we're talking about hormones at different times of the day. And he's like kind of freaking out, like he couldn't even ask me the question, And but it's true. Men have the highest testosterone in the morning. It peaks around just before lunchtime, starts to droop a little closer to 4 p.m. So, men have different optimal times as well. And there are person-to-person variations. There's genetic variability. It's sort of like there are some night owls, but, the vast majority of us should go to sleep at certain times. So there are variations in this that are genetic.
Okay. There's one more question and we'll move on. It said, well, two questions. Is it important to have our adrenals tested if you are postmenopausal? Is the first question from Connie.
I would. I mean, if you're feeling any fatigue or anxiety or things like that, that's the first place I would start.
Okay. And then Veronica asked, do you recommend bioidentical hormones? Is it safe to take them for the rest of your life?
I'm not a physician, so I don't use bioidentical hormones. I refer to physician colleagues. The data mostly shows that using bioidentical hormones younger is the safer thing to do. But it's really a case-by-case basis. It depends on your family history of cardiovascular disease and things like that. So that's a physician question.
Okay. All right.
All right. So I'm going to power through a little bit because I know we have a lot of content here.
Okay.
But menstrual cycle red flags, very painful periods. That is not normal. Nausea. You shouldn't have to miss work or school for periods. Pelvic pain that's not related to the menstrual cycle, heavy bleeding, very light bleeding, missed periods, irregular periods, PMS, including acne or mood changes. All of these things should be further assessed. So it's ideal for us as coaches to really start working with women through all phases of their lives and recognize that, anywhere you decide to work, this hormonal work will become valuable, whether you're working with teens and tweens or women who are trying to conceive or women during breast cancer treatment or recovery. This hormonal piece is a big key in all populations. So we want to make sure that the stress hormones are healthy. So what can we do about this if we've talked about the different pathways. Now, what do we do about them? Well, we talked about how stress can come from a number of ways. The four main categories are perceived stress. So that's the emotional stress, the unpredictability of life, when you feel out of control, that's emotional stress. Circadian disruption. If you're working on shifts, variable shifts are the worst, but night shifts and things like that are not ideal either. A lot of my clients are world travelers for their jobs, and so jet lag is an issue. Light dark disruption, which mostly comes from blue light devices being on too late at night, and not having enough exposure to actual daylight. Inflammatory signaling is stressful. Glycemic dysregulation, blood sugar imbalances are stressful. So cortisol is the stress buffering hormone. It's produced by the adrenal cortex primarily. It raises blood sugar, blood pressure, and it has some anti-inflammatory and some immune modulating factors, lots of other influences. It's better for women, and we go deep into this in my course and my program, to use the tender and befriend response rather than the fight or flight response to buffer stress, because having just chronic cortisol secreted is not optimal. So what happens then? So the adrenals release the cortisol, then the targets of cortisol are the brain, different parts of the brain, the cognitive part of the brain, the fear and anger part of the brain, the wake sleep centers of the brain, also all of the hormone axes that we've talked about, as well as the GI system, the cardiorespiratory system, the metabolic and immune system. So if your body is constantly releasing cortisol, you can see how your clients can be feeling pretty bad systemically, because their digestion can be messed up. They can be having heart palpitations. They're retaining belly fat. They're, be having autoimmune factors, or just getting chronically sick. They get every cold and flu because their immune system's suppressed. So you'll see brain fog and memory issues, because those are executive and cognitive functions. You'll see anxiety, insomnia, thyroid issues, reproductive issues and sexual issues, digestive issues, heart palpitations, and susceptibility to all kinds of immune dysfunction. So when we do saliva cortisol testing, you'll see we test this 4 times during the day so that we can tell when the problems are occurring. And there's a normal rhythm for cortisol. It should be high in the morning to gently wake you up from sleeping. You shouldn't need coffee. Cortisol is supposed to do that. And then it gently drops pretty swiftly the first 4 to 6 hours of the day, and then stays kind of a low, moderate level the rest of the evening and all the way down at night. So because cortisol inhibits melatonin. So if you're if you're working out, if you're doing a CrossFit class at 10 o'clock p.m., it's going to be really hard for you to go to sleep, right? Mm-hmm. And so we have to respect the cortisol curve. If the cortisol curve is off, we want to go back to the stressor. Ask your client, you're using your coaching communication skills. Where is the stress coming from in her particular life? And then stress and insulin, cortisol and insulin play off each other. Insulin shuttles blood sugar from the bloodstream into the cells. When bloodstream blood sugar gets too low, cortisol increases more blood sugar, because that number is quite tightly controlled. It's a survival issue, as we were talking about before. And so when your client wakes up and has sugar, their blood sugar gets too high, they're eating just grains and donuts and coffee and crap, then they're going to be then their blood sugar's way up, and then insulin comes in, then it drops way down, and then cortisol kicks in and it goes back up, and then insulin kicks in, and it's like an all day long thing. Our system was designed to do this a few times a year, not 4 times a day, which is, if you're on the standard American diet, that's what's happening. So what do we do? Well, we are going to assess for food sensitivities, have breakfast. I focus on savory foods in the morning, within 30 to 60 minutes of waking. Eating consistently. We've got to stabilize blood sugar before we do anything else. So might have to eat every 2 or 3 hours, depending on your client's blood sugar instability. Then we try to eventually stretch it out to every 6 hours, because that's essential for digestive health. And, limit sugar, restore nutrient deficiencies, and we use certain herbs and supplements to support this. Also, there's a lot of lifestyle medicine that we can do, breath work, orgasm, anything that quiets that it activates the parasympathetic nervous system and quiets the sympathetic nervous system. We're trying to keep these clients calmed down. When your thyroid is out of balance, your client feels out of balance, because look at all these things that the thyroid regulates: heart rate, body weight, muscle strength, menstrual cycles, body temperature. So they can have so many symptoms. And, the ranges, as you probably know if you've talked a lot about autoimmune thyroid disease, are just not accurate. And we have good data that shows the accurate ranges. They're just not used clinically. So you want your client to be in the accurate range of TSH, and then the optimal ranges of T3 and T4, with very few to no thyroid antibodies. Even just a little bit of thyroid antibodies predicts a higher level of eventually developing overt hypothyroidism. Now, this is an immune system problem, not so much an endocrine problem, but it ends up obviously becoming an endocrine problem. So what do? Lots of nutrients in food. Thyroid needs tons of nutrients, but we have to get rid of the problem with gluten. We have to get rid of gluten and other foods that look like gluten, is that there's what's called molecular mimicry. So the thyroid tissue looks a lot like gluten to the immune system. So when the immune system is sensitive to gluten, it's attacking gluten and the thyroid. So certainly, we have to be careful of that. And foods that cross-react with gluten, we can do some testing to see what that looks like in an individual person. Lots of micronutrients. So what is depleting her? So this is where the coaching comes in. Before we start just giving people handfuls of supplements, let's find out, why is she so depleted? Can we fix the cause rather than having her be on a lot of supplements? Is she not eating enough raw food? Is her digestion not able to absorb food? Even if you get a lot of clients who come in and they're like eating the perfect diet, right? They're paleo, vegan, plant-based, and they're like, I'm eating all the right stuff, but their digestion can't absorb it. So that's a huge problem. Sleep. So even a partial sleep restriction was accompanied by a statistically significant reduction in TSH and free T4, mostly just in females. So sleep, 90-minute cycles, roughly 7.5 hours per night. Going to bed prior to 9:30, 10 p.m. is essential for thyroid health. And again, we can go a lot deeper in the program, but let's talk about sex hormones too, because again, we want women to feel better. So we talked about the pregnenolone steal. I wanted to give you a simpler diagram to use to explain to your clients so they're not like, genetics and biochemical, pathways. Essentially, if your body is stressed, that's the priority. Your body is going to make cortisol out of the fat that you have. So if your clients are on a very low fat diet, they're working out a lot, they're stressed at work, they're stressed in their relationships, it's going to be extremely difficult for them to make the adequate sex hormones that they need to function. And not just from a reproductive standpoint, but from a life standpoint, brain focus, bone health, energy, all of these things. And as you said, Carmen, survival will always be a priority over sex and reproduction. In nature, we just can't go against the fact that we're animals.
Right, exactly.
So the other thing that's important, and I learned this recently from a colleague of mine, Cheryl Burdett. She did a lot of work looking at the data on, okay, so we give people all the right, because they do bioidentical hormones and stuff. She's a physician down in Atlanta. But why do some women have hormonal problems, even if we're sort of supporting this all correctly? Well, it's the environment of the body. So if the environment, when the body is chronically inflamed, which very often goes back to the gut or goes back to some chronic lifestyle stressor, work, they need to get a divorce, something that they're not addressing, but as a coach, we can start getting to the root of. Someone who's raising a sick child. I mean, there's lots of reasons that you can be chronically inflamed, not getting enough sleep, obesity. So if the client is chronically inflamed, if you have markers of that, like high F2 isoprostanes, which is just a marker of inflammation and oxidative stress, and especially if they have low glutathione, which is an antioxidant that supports metabolism of the hormones, you'll have increased risk of estrogenic cancers. And as I talked about in the very first slide of all the sex hormone biochemistry, there are different pathways where estrogen can break down. And when a person is chronically inflamed, the body chooses those more dangerous pathways, those more cancer-causing pathways.
And can't you, if I may interrupt for just a moment, you may be touching on this again in a minute, but since that slide was up, I have done all of that, the oats testing, the Dutch testing, the all of, the glutathione, all of that. I'm like a geeky investigator. Like if I even get like a sniffle, I'm like, could that be a parasite from the post-nasal drip, or it could be this? Like I'm not a hypochondriac, but I'm learning about these things because I'm fascinated by it.
Yeah.
So when you speak about increased oxidative stress, of course, we're talking about free radicals in our bodies coming from anything, could be anything, things we're eating that are wrong for us, environmental toxins, your neighbor's weed spray, whatever.
Smoking.
Yeah. I mean, exercise that your body can't tolerate and so on. Do you recommend the organic acids test for that particular for not diagnosing, we don't diagnose, but we would send our clients to someone to get that OATS test done, organic acid testing, to check the oxidative stress levels.
Well, and low glutathione for sure. You can see an oxidative on a organic acids test. You know, oxidative stress you can also just see, right? You can do heavy metal toxicity testing. You can do persistent organic pollutant testing. You can look for immune markers in the stool testing. You can measure in the blood HSCRP, which is a great, or homocysteine, which are good measures of inflammation. But honestly, you know, if your client's breathing really shortly and their face is always red, and, you know, I think sometimes we have to just stop for a minute and make some educated guesses. It's not always necessary to do like $4,000 worth of testing.
Right. Right.
And that's what physical, you know, as a clinician, that's what my physical exam skills are for. You know, I'm looking at someone's tongue and their fingernails and their skin and feeling the heat and, you know, things like that. Because if your client's just like, oh, you know, they're revved up, they're just probably under oxidative stress.
Right. And losing their eyebrows on the outside. That's a nice signal. Thyroid.
That's a thyroid issue. Yeah.
Okay.
So, but you can definitely look for all of these markers, high F2 isoprostanes. There are a lot of complex cardiovascular tests that go really deep into different markers of inflammation or chronic oxidative stress. And you can look at all of that stuff, but you know, it's just sort of a clinical decision about how deep you need to go.
Got it. Okay.
So what can estrogen metabolites show us? You know, this is where we look at, the 2-hydroxyestrone is the best pathway for breaking down estrogen in terms of it being less dangerous for cancer. 16-alpha hydroxyestrone, again, we want to look at the ratio. So see how that says favorable 2:16 ratio. That's what we're looking at. It's not that we don't want estrogen to go down these other pathways at all. We just want them to be in the more right size zone. Now, so this client's 2:16 ratio looks good, but her 4-hydroxyestrone is high. So we need to look for cleaning up oxidative stress, because that is an indicator that she could be at risk for like things like ovarian cancer, because 4-hydroxyestrone is a less desirable pathway for breaking down estrogen. You know, the data was clearer before they started studying it further. So the 2:16 ratio is a little bit not as clear as it used to be for breast cancer prediction. And in fact, elevated 16-alpha hydroxyestrone may be good for blood pressure. So you have to think about what you're looking for here. So for healthy sex hormones, start with stress hormones, as we talked about. You've got to make sure that the HPA axis is working optimally. Then we want to address any underlying causes of chronic inflammation, which we just talked about, and then find and address the sex hormone imbalance. So for example, with excess estrogen, fat cells also produce estrogen. So for clients obese, that could be a problem. Now, interestingly, premenopausally, it actually lowers estrogen levels to be higher in fat, because it just mucks with your menstrual cycle and the ovarian produced estrogen. But postmenopausally, because there's less estrogen being produced, none from the, or very little or none from the ovaries, and only in modest amounts from the adrenals, it tends to increase estrogen dominance postmenopausally. Now, they've done different studies to see if we can, you know, increase estrogen, increase body weight at a certain time to try to build bone health. That doesn't really work, so we don't do that. High insulin increases estrogen, which can be a problem depending on where your sources of meat and dairy. Lots of estrogenic meat and dairy out there from animals that have been injected with hormones. Alcohol, any alcohol at all, raises breast cancer risk. So if you have a lot of breast cancer risk in your family, I would minimize or eliminate alcohol. Stress and different micronutrients and macronutrients that make it difficult to detoxify estrogen. We could have a whole lecture on the detox phases, but you know, we'll save that for another day. So symptoms: breast tenderness, painful periods, PMS, being careful with things like maca and flax seeds and soy with clients who are more estrogen dominant or have endometriosis. mood swings, headaches, or breast and endometrial cancer. Also, we want to remove estrogen mimicking chemicals. And I think you talked to Laura Adler, who does some teaching for us. I mean, brilliant. Like one of the most important things that we have to think about with xenoestrogens is 80% of American women have been on birth control at some point, birth control or hormonal birth control pills.
Yep.
All of them pee. 0% of the city like water supply filtration does anything about that. So if you're not filtering your own water, you're by default drinking estrogen.
Oh my gosh. Yeah.
Probably lots of other stuff too, like antidepressants and stuff like that. So, so we have to be mindful and filter our water. And we have to support the liver to appropriately metabolize estrogen, cruciferous vegetables, and avoiding sugar-sweetened drinks, which are directly related to endometrial cancer. If we have too little estrogen, that's likely because we're over exercising, not getting enough fat, or we could be on birth control pills. We talked about that elevating sex hormone binding globulin. Now, there are times when it's normal to have relatively low estrogen. So if you're postpartum or breastfeeding, be mindful of that. Symptoms will be irregular cycles, low libido, anovulatory cycles, vaginal dryness, and I talk about here postpartum and in perimenopause. But in perimenopause, we want to optimize the HPA axis, and then often we have plenty of estrogen for what we need. We don't have estrogen for reproduction, but we're not interested. Most of us are not interested in reproduction anymore at that point.
No.
Painful sex is also an issue with too little estrogen. So how do we raise estrogen levels? Eating more fat, stop drinking alcohol, stop drinking caffeine, eat organic fruits and vegetables that are high in vitamins E and C. I should have put in there. Organic pomegranate. Pomegranate has a fascinating history. There are whole churches in Italy that are built on pomegranates for fertility, which is fascinating. And there are times when organic soy, if a person is not sensitive to it, especially if it's fermented, can be beneficial, and it depends on their genetics. Again, it's a little bit of a complex discussion, but there are times when soy can be beneficial in this population. So we want to start by understanding those pathways that we talked about, how they interact with each other, how genetics really impacts the ability of all of these pathways to function, and how these pathways interact with digestive function. If you can't absorb the pieces of the puzzle that build out these pathways, they're not going to function well. And if your immune system is targeting any of the tissues or the cofactors along the way, it's not going to work as well. So, and symptoms are often related to those target tissue functions, like we talked about, like if, for the thyroid example, that thyroid hormone impacts metabolism. So they'll be gaining weight if the thyroid hormone is not able to get to that target tissue. Stress, whether it's a physical stressor like standard American diet, inflammation, or an emotional stressor or a circadian rhythm stressor, is generally at the root of the hormonal balance. So we want to start with a whole foods, nutrient-dense diet that's free of chemicals when possible, address micronutrient deficiencies and digestive function problems. If it's autoimmune related, be mindful of cross-reactivity. So we don't want to feed our thyroid clients anything that looks like gluten. And then here's the link where you can download the slides and get a recording and, do anything else. Ask me questions there if you have any other questions on here.
Awesome. And I'll be sharing all of this when I share the recording with the students, I plug in links and give access and everything to you. And, what I find over the years of coaching, it used to be, I've seen a trend. It used to be, okay, it's, you start with food and then it went to start with leaky, helping them with their leaky gut. And then it's, no, you got to work on this. And for me, there's always been this niggling thing underneath that says it's stress related. Everything that happens to us has to do with stress, whether it's a food we're eating that's not working for us, how we're perceiving our lives, childhood trauma, everything in the back of my mind has always said, start with dealing with stress. It's never a place to start. And you just really solidified invalidated the thoughts that have been going through my mind over the years about how we're leaning into helping our clients. And even down to when you were just talking about, digestion, which we all know stress inhibits digestion, but so many times coaches are leaping over the stress
right
right into food and, gut, and sending people for labs and starting in the most complicated places instead of starting with the foundation of peace and well-being. Really.
Well, and clinicians are doing that as well. And I think we have to be really mindful of that because, I was actually talking to a naturopath who was struggling with secondary infertility. And, she was like, I cleaned up my gut and I've cleaned up my liver and I've done a liver cleanse. Blah, blah, blah. And I said, and how is your stress? And she was like, I know it's that, but I don't want to deal with that one.
Yeah.
And, it's a much more challenging piece of the puzzle to deal with, because if you have a low glutathione number on your organic acids test, you take a glutathione supplement. However, that's not going to fix it.
No.
If you really need to get a divorce or move or change jobs or get more help or ask for more help. And I 100% agree. And most of our programs now, the clients very often, the first thing they're like is, what can I eat? What should I not eat? We take about a month where we address personal responsibility and getting support networks built and looking at, honestly, at our stressors. And as women, I think one of the key things is and we work primarily with women, the practical demands on us are unprecedented. And we have to manage those demands. We have to say no. We have to be deliberate. We have to let things go. We've got to get a lot of help. Or, we're just literally going to burn out. So I think that is the most important place to start. And this is where coaches are so skilled, because we are comfortable sitting with people in very uncomfortable situations.
Yes. I love that. That's true. And one of the reasons why I actually, the students all get copies of my intake forms to work with clients. And one of the reasons I created such an in-depth 14-page intake form before we even meet with the client is because sometimes we have to know exactly what we're going into with where someone is with all aspects of their lives. And so that we can find a way to gently approach whatever it is that's happening with them, whether it's relationships or, self-esteem or how they see themselves or whatever. So I think that's a powerful thing to remember, is that we don't have to rush in with all this information about how to heal the gut. We just have to learn how to meet them where they are in the most important piece of their lives and bring that stress level down to where they can manage the gut problems, in my opinion, right?
Right, because sometimes, how are they even going to have time to cook, How are they going to have the brain attention if they're not sleeping? And sometimes we can use both of these things concurrently, because, if someone is really uncomfortable, then sometimes a supplement is going to help build a bridge, or sometimes a blood sugar balancing diet it's like there's mind body medicine and there's also body mind medicine, right? So you were asking me before, how do I deal with my intense schedule?
Mm-hmm.
Well, one of the things is that I really do prioritize physiologic self-care, which means I don't do anything until I've had breakfast. Nothing. I don't, there are things that I don't do at 9:30. I'm reading a novel and I'm going to bed.
Right.
And if I don't have that physiologic stability, it's much harder to deal with emotional and circadian rhythm stressors and traveling to Europe for 2 days. And, sometimes I don't go to bed at 9:30 because I'm on a plane, but if I'm not, 85% of the time you can use. So these things really go hand in hand. But I think the important thing as a coach is to set that expectation with your clients that this is a safe space to explore your stressors and play with creative ideas for how to address them. Because without doing so, the foundation of the hormone system, which affects, as we talked about, digestion, immunology, brain function, it's not going to be stable.
Right. Yeah. And then, interesting. I've taught my son when he was very young how to meditate, and, and have been installing apps on his little devices and giving him CDs to listen to and things like that. And when I got back from the Mindshare event, the very first thing I thought when I walked in the door, feeling that underlying buzz of all the things I had going on, was I need to step up my game on my meditation. Like and of course it is something that you don't want to do. You're like, but I don't have time for that. That's that voice that speaks to you over here. And then the other one was like, you don't have time not to do that. So I have created that space where my son and I, at least a couple times a week, we sit outside and we meditate to the same, music or whatever it is. And that alone can make me feel like a new person.
It's so true. Yeah.
It's crazy, but we talked about getting present and things like that. And I think there's no better way to do that, even if you only have 5 minutes, to just tune in and get present where you are. So we are definitely over your time frame. You've been overly generous, but let me ask just a couple more questions real quick before we end, and make sure I don't miss anything for them. Okay. So Mary Louise asks, she wants you to talk about progesterone a bit. This was early on, I think, in the talk, but she said she read that every postmenopausal woman should be using progesterone cream, although it wasn't clear why that claim was made. Beyond the fact that our hormones are just dropping as we go through the menopause experience, and that progesterone is our feel-good, so-called sleep well hormone. Is there anything else you want to add about why or if we should be taking progesterone?
I don't necessarily believe that. I think that there's natural reasons that we don't need progesterone, not as much progesterone anyway, just like estrogen. Now, if your adrenals are depleted and your other axes are not functioning well, you may have difficulty sleeping, and so it may be necessary. But again, I don't think anything supplemental is necessary by default. And supplemental progesterone inhibits the body's ability to make its own progesterone. So if you're premenopausal, I absolutely would not recommend supplemental progesterone as the first line of defense. It can be useful in short spurts, but it's like, I think of those things as like crutches or bridges. But it's sort of like melatonin. When we take these things supplementally, we inhibit our body's own ability to take them. And interestingly, like I was talking to a colleague of mine the other day, there's now like facial creams and stuff with progesterone in it, night creams. Don't do that, because progesterone and cortisol compete for the same binding protein. And if you have too much progesterone at night, your cortisol will go up. Then your melatonin is going to be inhibited. So you can't do any of these things in isolation. You've got to really think about the whole
chain. Yeah. Yeah. Okay. One more from Veronica. She said, my 20-year-old daughter has started having light periods that last 13 or 14 days a month. Should this be a concern?
Yes.
She's in college. Yes. Lots of stress. How would you recommend she address this with her daughter?
Well, you can't treat your own family because they're not going to listen to you. I would suggest that, you have her start tracking it, talk to a clinician locally, or, we work with people distance sometimes in our practice. Start tracking it, see if there's any pattern related to her nutrition or her stress. And, when you're in your 20s, you're resilient and you can often recover, but medications can have an impact. And so, this is something to address because we want to make sure we preserve her fertility and her bone health and her cardiovascular health. But, let's start tracking it. And you could do some testing, of course, but, she should have a workup for something like that.
Right. Last thing, sorry. Janice, is being wired as a night owl a myth? I think it is. I tell everyone I think that's a myth. We're all human beings, but you may have a different opinion. It's just she finds it hard to go to bed at 9, 11 o'clock works better for her.
Well, it is not a myth, actually,
really?
But it's just a smaller percentage than people who really, who say they are. A lot of it's habitual, but there are some genetic quote unquote night owls. And if you feel really good, if you feel really good going to bed at 11 and getting up at 6:30, 7, that's 7.5 hours, 8 hours of sleep. That's totally fine.
Yeah. But the 2 o'clock in the morning stuff, I don't think anybody should be doing that, in my opinion.
Well, and again, you'd have to look at the sleep data. There are some outliers, but mostly not. And the kind of optimal pocket for rest is 10:30 p.m. to 2 a.m.
Oh, really?
Yeah.
And then what happens after 2?
Well, you begin to start waking up, but you're you shouldn't just sleep those hours. You should sleep a good 7.5, 8 hours. But that's an important time because you switch to Th1 immunity. Your body is starting to do some repair work. Melatonin is the highest. Cortisol steadily rises through the night, just like it steadily falls through the day, because it's keeping your blood sugar stable. And that's all fine. That's what it's supposed to do. But melatonin your body does its repair work through that earlier part of the night when you're relatively earlier falling asleep.
Very cool. Okay. Jessica, I cannot thank you enough for your generous time and spending all the information has been really clarifying. Not only for me, I'm sure everyone is going to be like, wow, they want to watch it again. Everyone will be opting in for the slide deck, I'm quite sure. But I appreciate you so much. This has been really good. And I cannot wait. You have a sale. Let me mention this. You have a sale on the Hormone 101 right now. Is that right? Okay.
I do. I think it's till Tuesday.
Okay, yeah, I've got it written down here, okay. Hormone 101 sale from today through Tuesday, the 15th. So I am going to share that link immediately after converting the video, you guys. So keep an eye on the Facebook page. And, just thanks again. Just amazing. You're amazing. And I love all of your emails that I get all the time. They're entertaining. and I'll make sure that they are aware of how to opt in to get those emails from you as well, because they're always full of such great information.
Yeah, I think they'll get it if they get the hormone slides.
They will. Okay.
All right. Thank you so much. It's been my pleasure.
Yes, Jessica. All right. We'll see you later. Thanks again. Thanks, everybody. Bye.